तो वो सब एक दूसरे को जानते हैं। बट अभी मैं जो मेरे स्टूडेंट्स हैं पर्टिकुलरली जिनकी शायद फर्स्ट इंटरेक्शन है, तो मैं उनको बताना चाहूंगा कि डॉक्टर सेंथिल सर के बारे में जितनी भी हम चीजें कहें वो कहीं ना कहीं कम है, क्योंकि ये एक रिसर्चर भी हैं, एक ग्रेट टीचर भी हैं, फ्रेंड भी हैं, मतलब हर रोल में आप इनको फिट मानते हैं, ऐसी कोई दिक्कत नहीं है। और मेरे लिए तो खासकर मैं एक छोटा सा वाक्य आज शेयर करूंगा, शायद मैंने एक बार पहले भी कॉन्फ्रेंस में किया था, पता नहीं उस टाइम वीसी सर, एक्चुअली वीसी सर शायद जुड़ चुके हैं हमारे साथ। वेलकम सर, वीसी सर हमारे साथ जुड़ चुके हैं। सर आप अपने आप को अनम्यूट करें प्लीज। वेलकम सर।
Thank you, thank you. I'm sorry, I was in the impression of 10 o'clock. I'm really sorry to all the, I think, guests and joinees for this workshop. Right.
सर वेलकम सर। एक्चुअली वो हमारा प्रैक्टिकल और क्लासरूम सेशन है। देयर आर टू लिंक्स, वन लिंक फॉर इनॉग्रेशन सेरेमनी एंड सेकंड लिंक इज फॉर क्लास। मैं रिक्वेस्ट करूंगा डॉक्टर रवीना, वो प्लीज आ जाएं। और जैसा भी यस यू आर ऑडिबल मैम, बट यस यू आर ऑडिबल एज वेल एज विजिबल।
Okay, sir. Thank you, sir. Now start, sir.
Yes, please.
Namaskar, Adab, hello, and good morning. A very, very warm welcome to this beautiful, wonderful, auspicious day that brings together so many special people like I am Ravina Bhukkal, student of Jagannath University. Today, I am pleasure being host of this day. Today's conference topic is Concept and Technique in Manual Therapy. On the behalf of Department of Physiotherapy, Jagannath University, we all welcome our chief guest, Honorable Vice-Chancellor Sir, and respected today's speaker, Professor Senthil P. Kumar and Professor Ritu Sahani, Dr. Darshana Jani, Dr. Suleiman Sheikh, and organizer of this event, Head of Department, Dr. R.K. Mudgil, and all the my dear friends. It is indeed my honor to stand before you to introduce today's conference. Professor Sumer Singh is PhD in Management from BIT Misra, MBA from
Ma'am, you are muted. Ma'am, unmute yourself.
Thank you, ma'am. Had run several FDPs to develop home delivery and design skills of teachers and trainers. He has 36 years of experience as an engineer, corporate manager, civil servant, teacher, trainer, and academic administrator. 28 years in the area of technical and management education, training, research, and academic administrator, and 16 years with industry, private as well as government establishment, selected for Indian Engineering Service through UPSC at the early stage of his career, and has served as Group A officer with Indian Ordnance Factories Service up to the level of Joint General Manager. Prior to joining us as Vice-Chancellor, Jagannath University, Bahadurgarh, he had tenure as Vice-Chancellor at Career Point University, Kota, Dr. K. and Modi University, Nevai, and Sangam University, Bhilwada. During this tenure, he has given strong focus on formulation and establishment of system and process in order to set the transformational culture in the universities. Student-friendly approach and delivery of service with customer delight remains at 4 point. Professor Sumer is strong believer of lifelong learning philosophy and promoter of education as the best investment for the citizenry across the globe. Vice-Chancellor, sir, you honor us with your presence. Thank you. VC, sir.
Thank you, Dr. Ravina. So good morning to everyone. It's my proud privilege to address the inaugural session being organized by Department of Physiotherapy, Jagannath University, Bahadurgarh. in collaboration with Haryana Chartered Association of Physiotherapists led by Dr. Mudgil. I think first let me address the uniqueness of this workshop and the great person behind what I should say, somebody who will be with you for whole day, Dr. Senthil. And Dr. Senthil, if I correctly recall, once I was with Career Point University, Kota, and Dr. Yaduvanshi, Pushpendra Yaduvanshi, he used to mention about you and I think your area of expertise. But today I could see in your address, rather some write-up given by Dr. Mudgil. I think today, including me, all participants, students, faculty, and the researchers are fortunate that you are with us, you have spared time. And then the therapy, which is, I think, as old as our civilization, because I cannot forget the saints of our, what I should say, the father and even many people of the old generation, कि भाई उस डॉक्टर साहब ने तो हाथ रख दिया तो सारा दर्द दूर हो गया. तो whatever I understand, आपकी जो थेरेपी है वो हाथ रखने वाली ही है, ठीक है. और दूसरा यूनिकनेस जो मैं देख पा रहा हूँ, one word we are using the manual therapy, and whatever digitized platform you are using, that is again some great contrast. That at one hand you'll be talking about the manual therapy, but the helping hand or the great enabler will be your teachment platform. So I think all the community members, including students, me and other teachers, salute you that somebody who is propagating the digitized environment of learning in a great manner. So these are the few things which are unique to my understanding. As far as manual therapy is concerned, I have shared my own understanding, but I am the strong believer of once we hug each other, right? I do not know which are the nerves are being compressed or touched. We feel good. We feel good. Similarly, I cannot forget maybe my school days. Maybe one of our naughty classmates used to put something, maybe one nerve here, maybe along with an elbow, and you might be knowing better. Once you used to press that nerve, I think everybody used to cry. So this is my understanding about your therapy, but I think 2 days back only, our Honorable Prime Minister has again made a landmark decision through which he has promoted our own ancestral technologies, even in medical science, and that recalls us the era of Dhanvantari and many other people. As far as physiotherapy as discipline is concerned, I'm looking forward for that maybe within short span, though you already have it, but you will be considered at par with any MBBS or surgeon or anybody else, which was not in earlier days, right? So this is what from my side. I thank Dr. Senthil and other team members who are representing AOMPT. Dr. Darshan, I'm not able to see the full name, and Ritu Sani. So we are grateful to have you with us. And last but not least, the brain, the person, the personality, the professional behind this initiative is Dr. Mudgil. And I think once we talk about physiotherapy, 2 years back only I came in Haryana, but before that I was in Rajasthan, and everybody was knowing him from his profession, from his deeds, right? So I think this is what today's galaxy of experts, and same is with the listeners in form of students, researchers, and the faculty. So looking forward for great learnings. Thank you everyone.
Thank you, sir. Now
Your
I
meaningful
request
words
Dr.
inspire
Soni.
us. I invite Dr. Sonia, Assistant Professor of Jagannath University, kindly introduce today's conference speaker, Professor Senthil P. Kumar.
Good morning, everyone. It is my honor to introduce today's conference speaker, Professor Senthil P. Kumar. Professor Senthil P. Kumar, Chief Instructor, AOMPT, Academy of Orthopedic, Manual Physical Therapist, Qualified MPT, Musculoskeletal and Manual Therapy from Manipal University, and having 18 years of post-PG teaching experience, including 10 years Manipal University, 3 years at MM University, 2 years at Sharda University, and 1 year at Noida International University. He is now presently Director Research at Bethel Medical Mission Group, Hosmet Hospital Educational Institute under RGUSH, Bangalore. For past 2 years, he has delivered 183 keynote lectures as invited speaker and presented 39 research papers with 19 first prize in total 217 conferences held in 15 countries. Published 257 peer-reviewed journal publications with Scopus H index and is the world 13th most cited author on manual therapy with H index of 17 in Google Scholar. Conducted 120 workshops in 18 states of India and a total of 2,000 plus webinar hours this COVID-19 lockdown as a resource person. AOMPT is the world's largest manual therapy academy with 7,700 plus followers on its FB page and rated 5 by 5 star for all its online courses by participants from 52 countries. He is also an associated editor for Journal of Manual and Manipulative Therapy. Thank you so much, sir, for being a part of conferences. Sir, now you can proceed. Thank you, sir. Professor Senthil P. Kumar.
Yes, first I would like to take blessings from our senior most academician and also the leader of inspiring and also developing the profession of physiotherapy in wherever universities in his capacity as a Vice-Chancellor and also present today as our chief guest for this day, Professor Dr. Sumer Singh. Pleasure to have you, sir, and amongst us. We always believe that the greatest, when we see in the head of the family, it is always the father. And same way, if it is the academic head of the university, it is always the Vice-Chancellor. So you are the person who actually nurtures and provides the best learning environment for our budding physios, especially with Jagannath University, Bahadurgarh, improvising in the aspects of research also. They're doing good research in physiotherapy, especially the master studies. And shortly you should promote by beginning even the PhD program. I think it's already there, Dr. Mudgil, PhD?
Yes, sir. Yes, sir. PhD is already
okay.
there. And 2 scholars are near to finish their PhD also.
Okay, so it's always a great thing there. So pleasure to have you here, sir. On behalf of the Academy of Orthopedic Manual Physical Therapists, which I am associated with, and also as part of every participant, because we always believe we all learn from each other. And I would definitely be glad if you could dedicate some time in between and be part of the workshop also to see what are these manual therapy techniques and what is going on. And why a person somewhere far and then Bangalore with a big introduction and he's taking this workshop. So what is actually he's teaching? Okay, so your presence will also motivate me. And I really appreciate the organizing team to put up such a collective effort in a shorter period of time. And of course, most importantly, when the discussions were going on, I was made to be aware that Dr. Mudgil got immediate approval from our Honorable Vice-Chancellor. So that is the reason why this is the best, what is called as it's kicked off very fast and it has become a reality now. So thank you so much, sir. And may God bless you with best health and full of energy to keep leading us and keep inspiring us. So we can begin if I'll give just a small overview. Yes, Dr. Mudgil sir.
Thank you, Senthil sir. अब जैसा कि हमने रिक्वेस्ट किया था सर, आप ओवरव्यू देना चाह रहे हैं तो प्लीज आप प्रोसीड करें अभी. उसके बाद हम सेकंड लिंक सभी के साथ शेयर करेंगे फॉर द मेन वर्कशॉप, because this link is only for inauguration ceremony.
जी.
Please proceed, sir. Please proceed for overview.
Okay.
नहीं,
So,
डॉक्टर मुदगिल, I think
yes, sir.
Yes, sir.
सर के लिए रिपीटेशन होगा and the other participants might be waiting. Why not to come on that link, and all the participants who are present here, they will be there only.
Yes, sir. They will be.
So why
there.
waste time? No. So Senthil sir.
Sir, we have not distributed the second link yet.
Okay.
Once this is over, only we'll distribute.
Okay.
So
then.
they will join as a continuity.
Okay. No
So
issue.
that
Please.
students don't be ambiguous.
Hey,
So they should not
personally,
get confused.
I love to learn. I love to learn.
That's why we are
And,
requesting for overview, sir.
Okay. So I want to tell in terms of this manual therapy as an overview, as an initial, what is called as a trailer for today's workshop. If, for example, we have to understand that there are joints, muscles, and nerves. So joints are actually the ones which are moving. Muscles are the ones which are contracting. They are working, okay, for the movements. And the nerves are the ones which gives the impulses to make the muscles to work. And they also take the impulses from the joint and the muscles on what condition they are working. So all the three domains, we have manual therapy techniques. So there are joint-based manual therapy techniques. There are muscle-based, or what is called as myofascial manual therapy techniques, and then the neural manual therapy techniques. In the joints, as there are two bones and we have the synovial fluid in the middle of the joint, and we have a capsule, synovial joint capsule. These joints are predominantly for major function of movements, and also whenever we are doing some movements with the muscle contraction, there is some compression and there is a distraction. So joints are mostly checked, and you assess the joints with taking the bones together towards each other, compression, taking the bones away from each other, that is distraction, and also moving one bone on the other bone. So in terms of gliding motion, gliding movements. So these movements check the mobility inside the joint. And of course, we also check these kind of movements, okay, like physiological movements, but we try to see that treatment will be making improvement to a patient, and that improvement has to be functional, because patient comes to us not because joint is paining. They come to us because they are not able to read for a long time, sit for a long time, getting up from sleep, they are getting stiff neck in the morning. After some time, the neck becomes free, or they feel like shoulder pain when they are reaching behind the neck or behind the back, or they feel some kind of sounds when they are bending and straightening the elbow. And also after writing, they feel that the wrist becomes stiff. So major symptoms of the joints can be stiffness, restricted range of motion. And the next one is the joint sounds, like tuck, 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 tuck. Every time it keeps on coming in the end of the movement. So that is a tuck, tuck, okay? Tuck, tuck. Every time it keeps coming. So this is like a clicking sound, which might tell that there is an instability in the joint. What we tell by instability is because the joint goes out of place. Tuck, 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 tuck. So when I'm moving, normal joint goes like this. Hypermobile joint will go tuck, 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 tuck. Okay, so this is what happens. So patient might feel that during opening the jaw, katak, katak, last in the end of the range it comes. That is clicks. But sometimes people who are having joint degeneration, not specifically because of aging, it's because of sedentary lifestyle. Because I always tell, aging is not the cause of problem. It is the laziness which is the cause of problem. So people who are active will stay young, whatever the chronological numbers will be, but their physiological numbers will be lesser. Nowadays, we see more elderly are doing the jogging, walking, yoga, and even working out in the gym and also participating in the sports compared to the younger generation. Okay, so younger generation which is sitting with only all the digital devices, PUBG syndromes. So we have all these situations which makes what is called as the joints to become the synovial fluid to be stagnant. It will not be mobile. It will not be distributing everywhere. Okay, because we are in one sitting position for a long time, or standing position for a long time, or we keep the joint bent for a long time. So what happens is the fluid actually becomes thicker. Also, there is a popular tendency nowadays for people to understand or misunderstand that you take more water, you will put on weight. So they want to reduce the water intake. Ultimately, that is the reason for the joint fluid to become lesser. And moment the joint fluid becomes lesser, the friction happens between the bones because fluid is less. The lubrication not there. Nutrition to the articular cartilage not there. So then after that, the degeneration process starts, even in young people who are sedentary. So sedentary lifestyle is the cause for degeneration of the joints. Also, together with our Indian population, generally they have the calcium deficiencies and the vitamin D deficiency, which actually aggravates the bone to become more weaker. So that makes the joints to become also abnormally getting forces, because the bone, its natural normal alignment, normal weight bearing is there. If the bone becomes bent, okay, bone becomes bent, the contact forces changes. So then the joint goes for damage. Some of these treatments might require surgery when too much of a deformity restriction. Definitely, orthopedicians have a replacements, but physical therapists have a big role. The disability into what is called as the functional ability. So our role is actually to concentrate on how fast we can make the patient to be functionally independent and normal. As much as possible, we'll try to make them normal. But if the damage is beyond a stage, we cannot reverse it. So then what happens is, in the existing condition, how can we improve their functions using muscles? So sometimes, because joint and muscles are both together in the body, so if a joint is weak, muscles can try to protect it, muscles can try to make it more stronger. So it's all a teamwork. One is not, one is tired, one is on leave, another one works. So same like that, joints, muscles and nerves can actually go for what kind of a adaptation or a compensation. If one is in problem, other one will go for a adjustment. Okay, so trying to make sure that our body functions normally. So this happens. So many of us may have a genu valgum. The knee joint will be bent like this, or genu varum, bent outwards. But we won't have knee pain at all, because in that abnormal position of the joint, the muscles are stronger. So there won't be any symptoms. The moment the muscles become weak, joint is already out of position, muscle also becomes weak, then only the symptom as such starts coming in the patients. So young patients, maybe if water or blood related, women have a risk factor of this hemoglobin anemia or the monthly hormonal imbalances, because of which the blood circulation in women might become slowed down. So what they eventually have is, it's primarily a muscle problem. So myofascial problems are common in women. In the joints, they have hypermobility because ligament laxity. In men, joint degeneration is common, joint stiffness is common, and you have a muscles in terms of not a kind of a weakness related trigger point, but the muscle will be tightness and then trigger point. Okay. So that is shortening of the muscle with the trigger point. So lengthening and weakness of the muscle with the trigger point common in women. Okay. So you can see these are all some distinct pictures of commonness. Okay. But there is this commonness is only 80%. 20% there will be a lot of differences. We as a clinician, when will we suspect that there is a nerve injury? That means either there is a risk factor for the nerve injury. What could be the risk factor? Vitamin B12 deficiency. So that is what is prescribed as the Neurobion, the tablets. Okay, whenever we have a tingling and numbness symptoms because of nerves by the neurologist. So remember that vitamin B12 deficiency or even what is called as diabetes will make the nerves to be weaker. Because of which, instead of a muscle getting strained or the joint becoming what is called as the ligaments becoming sprained, the nerves go for strain. So we are keeping the elbow on the table and we are supporting like this. We might have a compression of the nerve, which we feel that electric current when we tap at the medial epicondyle. We'll feel it at the little finger. Okay, the current sensation. That is the ulnar nerve. And the same way, typists, those who do a lot of typing and target-based work, they get thumb numbness and burning sensations in the night. In the duty time, they have symptoms, but they cannot tell that I have a symptom. So they have to work. At the end of the day, in the night, they develop what is called as carpal tunnel syndrome, which is actually compression of the median nerve in the wrist. Okay. So this is again a common problem in computer or the software engineers, and of course in surgeons also, because they hold the tools and they keep on operating for a longer time. Even dental surgeons and also the plastic surgeons, those who take a longer time, neurosurgeons. Okay, so they go for a lengthy operation theater duty. So it's important for us to recognize that for our particular patient, whether articular is the problem, whether it is the myofascial problem, or it is the neural problem. A typical symptom of, I am feeling it is stiff, okay, my movement is not free, or I am getting sounds when I am turning, okay, definitely it is joints. And you also have like standing, bringing knee pain, walking, bringing ankle pain, okay, all this stair climbing, getting hip pain. So sitting causing back pain. Lying down, there is no back pain, because sitting is weight bearing of the spine. In lying down, there is no weight bearing on the spine. So this compression distraction will tell us that the symptoms will be coming. So that is joints, movements and sounds, kinematics, okay, which we call it in biomechanics under physical therapy. So in myofascial, young subjects, mostly they get the myofascial problem. First, whenever we get a pain, it's always a muscle pain. We tend to ignore by taking a rest or by modifying the activity. And after some time, we might feel better. And again, after 2-3 days, again, that same activity brings the pain. So the muscle pain, then the joint pain starts. Okay. So it comes like that. So first onset is likely to be muscle pain and the pain that comes at the end of the day. Joint pain might come in the morning with the stiffness, and that stiffness eases with the movements. When I'm getting up from sleep, I'm having a stiff neck, I'm having a stiff shoulder, but I start doing my activities, my shoulder becomes free. So that is joint symptoms. But muscle symptoms will come in the evening, because whole day the working or contraction of the muscles, and evening the muscles become stiff. And after that, when you are talking of nerves, it is a more distributed symptoms. Joint means the subject will show like this with one finger. Here is my pain. Here is my pain. Here is my pain. Okay, finger. But muscle means the subject will show like this with the palm, not the finger. Okay, here I am paining. Here it is paining. Okay, so they'll show like this as a rubbing. And they also know that any kind of applying an external application, immediately the ointments or the creams, pain relieving creams, they get better relief if it is a muscle problem. Okay. And they also get better relief with the heat. They apply some hot pack and they feel better. So you're likely that it should be a muscle problem if the patient is also showing with the palm. Okay. And it is a young patient and first time pain at the end of the day. Okay. Overuse. We tell that overuse symptoms at the end of the day. Now, the subject will tell like a line of pain. So they'll show like this. Okay. Joint means I will show like this. Here it is paining. Here it is paining. Okay, so that is joint, likely to be joint. But if I show like this as a finger which is traveling along a line, that is nerve pain. And in addition, a feeling of numbness, a feeling of something moving in my fingers or my hand, tingling, and sometimes even electrical current-like sensation, which comes from the neck or the lumbar spine back to the leg. So all these are neural. And always remember that neural also is same way vulnerable like muscles and joints. It is not like after muscles only nerves will get affected. Nerves will get affected first in people who have the risk factors for nerves. So that is why it's important for us to check. And nerves can be easily checked by touch itself, because we can touch along the nerve and we can see that it is producing that same numbness or the tingling pain, whichever the nerve problem is. Also nerve, if they are damaged to a larger extent, you will find that compared to this hand, the sensation will be less. Okay. You will tell that if this thumb, if I am touching means I am feeling like it's normal, but here if I am touching, it's not that much, it's less. I feel like I'm wearing 2-3 gloves. Above the gloves, you are touching me. Okay. That is reduced sensations. And also the weakness of muscles. You might check the grip strength of my left hand. My strength will be better, but the grip strength of right hand, it will be like weaker. Okay. I'm not able to grip. Okay. So that tells about the motor functions of the nerve. So sensory, motor, and also what we assess as the reflex testing. So that again will be a neurological damage if reflexes are altered and diminished. Okay. So these are the things which will show us about articular, myofascial, and neural. And we have concepts decided for or addressing more to the articular system, like McKenzie concept. The McKenzie concept is the first one which we are going to start now, which is dependent upon posture. So our sitting posture, standing posture, lying down posture, all these postures and also some of the movements in those postures. That is McKenzie concept. It is popularly called Robin McKenzie's mechanical diagnosis and therapy. So this is the first one. The second one, this comes as per the clinical assessment, because we always observe the posture of the patient when the patient walks into our clinic. And we see that how the patient is sitting, how the patient is standing. Okay, so what they are comfortable, what they are not comfortable. So posture is first. The next one, we ask the patient, what is the one which is causing your pain? And they might tell that looking up like this, it's causing, or taking the arm up is causing, or stair climbing is causing. So it's an activity that causes, which is functional. So functional activity, the manual therapy technique is Mulligan technique. So that is Brian Mulligan. If you can give mobilization in a functional position and for a weight bearing position, you can give mobilization of the joints. So that is Brian Mulligan's mobilization with movement. So that comes second. And then the third is people who do not have functional problems with the activity after walking or after stair climbing, but they have pain even in the lying down position and then bending and straightening the leg or moving the elbow, the joints. So it's not a functional activity, it is anatomical activity itself, they are having pain. I am not telling that having food, I am getting shoulder pain. I am telling that I am lifting my arm like this, I am getting shoulder pain. So that is a kind of anatomical movement of flexion. So then I know that More structurally, what I can apply for the joint is Maitland's concept. So that is Jeffrey D. Maitland mobilization techniques. This is more anatomical, and joint also, if you are seeing how the joint is, it indicating in a Mulligan, the joint will be normal. Okay, moving also, it's fine, but in the end, it will be paining, coming back, no pain. That is Mulligan's concept. Whereas in the Maitland, joint itself will be a little bit abnormal. When we palpate, you will find that the joint surfaces are abnormal. Okay, so at rest itself. So you have to correct it at rest. So this is called as the static malalignment. So which will indicate a Maitland's mobilization technique. And the fourth one is you might be trying to improve a flexion, and then later you improve the supination pronation of elbow, or you did the abduction adduction. After that flexion extension you have improved, but your target should be a three-dimensional position which involves a flexion and abduction or external rotations in combinations. Same way neck also, improving flexion extension, subject will not become normal. Making the lateral flexions to be full, subject will not become normal. You need to get extension with lateral flexion and with rotation, combined one. Then only it is normal, then only subject has become fully functionally normal. That three-dimensional combination of movements is a progression from Maitland and what is called as the Mackenzie. After that, you apply what is called Edwards concept, Brian Edwards combined movements. And then the fifth of the articular concept, which involves multiple techniques for soft tissue injuries, which is explained by James Syriacs. So he told that soft tissue injuries can be assessed easily by palpation. You can assess it by active movements, passive movements, and resisted isometric tests. So three combination of tests called as selective tissue tension tests. And tissues are divided into contractile and inert. And you can divide active structures or passive structures in the soft tissues, like muscle and tendon are active structures, fascia, whereas other structures, all of them are the passive structures. So these treatments are given as soft tissue injections. Acute stage, there is inflammation in the soft tissue, so we do soft tissue injections. Subacute stage, there is a healing of the soft tissue, which might happen with adhesion or scarring. So we give deep transverse friction massage, okay, so that the fiber orientation will be normally happening during the healing. And then the last chronic stage, where the adhesions have set in and you want to break it, for which manipulation and thrust techniques. This was also described by James Syriacs. So you have manipulations for extremity. If I have a rheumatoid arthritis, my fingers are going for stiffness every time. And then I find that whenever I am moving, I'm finding sounds, okay? So then definitely I should see for how I can do a distraction technique with the rotation, okay? And then at the same time flex. So distract, rotate, and then flex. Distract, rotate, and then keep flexing. So this is a loose body manipulation technique. Other one is, of course, the thrust manipulation, which is like the distraction of the neck and then rotation and thrust. Okay. Even lumbar spine also thrust manipulation techniques of Syriacs. So remember that injection, deep transverse friction massage, and manipulation are Syriacs treatment. Assessment of Syriacs is selective tissue tension test. And then you come for the myofascial techniques, which are 4 techniques. First one is for spasm, constantly paining, patient is coming with discomfort, shortened position like this, splinting the muscle with the hand. And that patient, you keep the muscle more shortened, okay? So that spasmodic muscle spasm becomes relaxed after 1 minute. And after that, you will find that it's easier to move the neck, even opposite side. So that is called as the positional release technique. Whereas the next one is the soft tissue techniques, like you might get a point in the muscle where the pain is too much. And when you are pressing that area, the pain will spread to the other regions, okay, called as referred pain. and this is called as the trigger point. So muscle is there and the fascia is there. So I can go for releasing the fascia. So this is a palmar fascia, and this is actually the flexor retinaculum release. Okay, so I can do like this for carpal tunnel, or I can do a trigger point release where directly on the trigger point, I can keep my index bent like this and give pressure. Okay, so this ischemic compression, this is also maintained for 45 seconds. How much pressure is given? Pressure till the pain is 7 out of 10, not more than 7. Okay, so initially it will be touch, pressure, yeah, 1, 2, 3, 4, 5, 6, 7. Okay, so 7, then you maintain. Okay, so these are techniques like myofascial releases. And then the next one, we have the muscle energy technique, which is an active technique. That means you are giving activation of muscles. So if a muscle is problem, you can activate the same muscle or you can activate the opposite muscle. Both options are there. If the muscle is tight, tightness, okay, passively shortened muscle, I activate the same muscle 5 times. After that, the muscle will be lengthening. Whereas if the muscle is in spasm like this, I activate the same muscle, spasm will worsen. So I will activate opposite side muscle. It will reciprocally inhibit this side spasm muscle. So that's where reciprocal inhibition or post-isometric relaxation. Both are muscle energy techniques. Muscle energy techniques can be used for joints also. You are contracting the muscle and it is correcting the joint positions, like facet joint dysfunctions of the spine. And primarily all this positional release, myofascial release and muscle energy techniques are from osteopathy. And then later scientifically adapted and utilized by physical therapists all around the world. The importance of this myofascial technique, one more is there, called as the motor control retraining. So that means there are muscles which are stabilizers, like rotator cuff in the shoulder, or we have the what is called as the deep cervical short flexors in the neck, or transverse abdominis and multifidus. So they're training those stabilizer muscles is called as the motor control retraining. It's important for everybody. Any musculoskeletal disorder, you have to give the motor control retraining because it will prevent the recurrence of symptoms. Okay, so functional recovery, it depends upon the motor control, proprioception, neuromuscular control. So remember that. And also you have neural. It's basically only the 2 people who have actually explained about nerves. One said that if you are taking the upper limb in a combined position, like abduction and external rotation, supination, wrist extension, after that you extend the elbow. Okay, you find a stretch in the arm, and that stretch in the arm increases when you are bending to opposite side. Stretch in the hand also increases when I am bending to opposite side. When I am bending to same side, the hand stretch reduces. Because what I have done as a position is the median nerve elongation position. So I'm actually pulling the nerve to evaluate mechanically how the nerve adapts to tensile forces. So some patients may have symptoms when I'm taking like this and doing this itself, they'll get numbness in the hand. And then I do this, that numbness in the hand will be changing. So I know that it is the nerve and it is mid-range symptoms. So it's a nerve sliding problem. So what I do as a treatment is I do this without reproducing the numbness, and it is easily done by the subject because here it is pulling, here it is relaxed. Here it is pulling and here it is relaxed. So this is the nerve slider. And of course, in athletes, they will not have mid-range symptoms. In initial symptoms, they won't have. If you do the neural testing in them, in the full length, and after that this, and then you maintain that position, then only they'll get symptoms. So those are tension dysfunctions. Nerve is not elongating. They're more like nerve stiffness. So you have to elongate. So for which you do this position only and keep it like this and go for elongating the nerve like a tension technique. Okay, nerve tension as a technique. So tensioner technique. Okay, so like that. So slider techniques. For those who have enrolled into the teachment on time, would have got access to some of the videos what I have already explained as lectures. And of course, all this with the demonstration on a student, which I routinely take for my students everywhere in the institutions where I was working. So that's study materials. And of course, that YouTube videos will give a much broader perspective of all these concepts. And of course, it's a what is called as a strong foundation of manual therapy. Okay, so from which you can build your skills further. So this is the overview of all these techniques which we are going to see today, but I'm going to tell you the demonstration, the improvisation of these techniques. So that means each one, how you can improvise. So, and I'm going to show it like the most important techniques, most commonly that is performed for every concept, so that at a postgraduate level, you find the improvisation. Okay, what is the improvisation? How clinically we can adapt these techniques. Because we must not be technique centered. That technique is taught like that, we have to use the same technique, same way like that. Never. And the same technique is used on 100 patients. Never. That is technique centeredness. Certified practitioners, certified instructors of McKenzie, Mulligan, Maitland, like that. But if you are coming to patient-centeredness, a clinician will know that each and every patient is different. And we should treat the difference, not the similarity. And the clinician will take the same mobilization technique on one patient in one method, in another patient in another method. So that makes you a clinician. And I want you all to get trained in the techniques, but ensure that your innovation and creativity is not suppressed by thinking that those westernized techniques are the best and they will do magic. Never. The magic is done by your passion and your sincerity to learn, to apply, and to communicate with the patient. Every clinician who is treating the patient knows that frozen shoulder, two patients, they are never the same. One will have problem with external rotation, another will have problem with internal rotation. So never ask, what is the treatment for frozen shoulder? That is only for syllabus. But for reality, you should ask, what is the treatment for a 45-year-old patient who is a diabetic with a frozen shoulder, who is having difficulty in reaching behind the back? Versus a 55-year-old woman who is having difficulty in doing overhead activities, not a diabetic. Both are frozen shoulder. What I'm trying to tell is this is external rotation and elevation, whereas this is extension, internal rotations. Both are frozen shoulder only. And the same way, even you are talking about any of the myofascial problems also, even our right side, left side itself is not same. Our muscles on the right versus left are not the same. The strength of the what is called as the right side versus left side. Right side is all, dominant side is always good in endurance. Non-dominant side is good in strength, but not in endurance. You get fatigued faster in the non-dominant side because it's partially sedentary. Not everyone is Amitabh Bachchan, okay, or Dr. R.K. Mudgil. Okay, so you have to think in terms of how well you have to individualize the treatments. Okay, in reality, it's impossible for teachers to teach the reality because reality has million combinations, million permutations. So they cannot teach. So what is possible is they teach as per the things that are actually available in the literature. But when it comes to practicals, yes, techniques. But in reality, the same practical technique will be modified. That is why in Maitland textbook also, he told that you give the posterior glide to the shoulder. That is technique, it is described in the textbook. But he needed give the posterior glide more laterally or posterior glide with the compression or posterior glide with the inferior direction. So combine that. see that which one helped that particular patient is the one which indicates as the treatment. So remember that what is best for me is what my body behaves best, what my body shows improvement in the technique. So it is very, very important to have that ongoing evaluation and to treat each and every patient. And even the patient on day 1 is different from patient on day 2. The behaviors won't be same, the structures, how they adapt, morning versus evening time. A patient comes in the morning to the clinic, patient comes in the evening to the clinic. Their endurance, their synovial fluid, their muscle circulation, the nerves, metabolism, everything will be different between morning and evening. And even summer versus winter, the temperature change happens, immediately the muscles will start fatiguing faster because you are sweating more because it's humid. Okay, so it's so hot, you are getting dry. So that means synovial fluid will be getting reduced. So these are all the human body adaptations. A normal person who is very well active and happy mentally will have easy adaptability. They will not get symptoms with changes in temperature. But a sedentary person will get symptoms immediately, okay? Which is the majority of the population, including even physical therapists are sedentary, okay? So students and all are maximum sedentary. They only participate in the sports week annually. Otherwise, daily no sports. They go to the gym just to take a selfie and put it on Instagram. Not for doing aerobics in the gym, okay? So always that our culture, our attitudes all determines, okay? So every person has a different psychological aspect also. Occupation is the social aspect. Family responsibilities is the social aspect. And biological is also different between two people. So biopsychosocial and articular, myofascial, and neural. So all this integrates, and remember that you must be a clinician. And we are going to see the distribution of each of these concepts, like initial 10 to 15 minutes of lecture presentation by Ritu Sani ma'am, and following which I'm going to show another 15 to 20 minutes demonstration on my model here. So she is with us. So it's going to be theory and practicals, and it's going to be switching between the PowerPoint versus the direct demonstration. Make sure that interactions can be done during the break time, but I'm not giving a formal break except the lunch break because since it is online, everyone will be having coffee when you are watching the lecture also, demonstration also. You'll be having samosas, okay? Or you might take anything except I cannot take, okay, in between during that. But still, for me, teaching itself is energy. So wish you all the best of luck. And we will share the Zoom link to join the workshop link, the Zoom link. So connect with us on the Zoom in the workshop and do not miss the beginning. Listen to our own Ritu Sani ma'am, who is the executive admin of the AOMPT. And of course, we have Dr. Darshana with us, who is also the general secretary of the AOMPT. So I thank Professor Dr. Sumer Singh, our Honorable VC sir, and we are going to start the actual workshop in the second link. Dr. Mudgil can also share the link with sir also, just to let sure, sir see in between always.
Sure. जस्ट अभी मैं आप लोगों के ग्रुप्स में जितने भी स्टूडेंट्स ग्रुप्स हैं, पार्टिसिपेंट ग्रुप हैं, मैं अनदर लिंक आपको सेंड कर रहा हूं जिसमें आप लोग ये वर्कशॉप अटेंड कर पाएंगे। और मैं अपने स्टूडेंट से फिर से रिक्वेस्ट कर रहा हूं, कल भी मैंने बोला था आपका सेशन बहुत इंटरेक्टिव होने वाला है। पेन पेपर नोटबुक लेके बैठिएगा, फ्लाइट में वो कहते हैं ना सीट की पेटियां लगा लीजिएगा, और अब हम फ्लाई करने वाले हैं। तो सेम सिचुएशन यहाँ भी है। रितु साहनी मैम आपको पावर पॉइंट प्रेजेंटेशन के थ्रू थ्योरी लेक्चर्स लेंगे आपका, और साथ ही साथ डॉक्टर सेंथिल आपको प्रैक्टिकली डेमोन्स्ट्रेट करके दिखाएंगे। तो ये कॉम्बो है और होपफुली आप लोग बहुत कुछ सीखेंगे। मास्टर डिग्री के स्टूडेंट्स के लिए तो मैं स्पेशली बोल रहा हूँ, क्योंकि जितनी भी टेक्निक्स हैं बेसिकली जैसा सर ने कहा कि हम जब टीचिंग में रहते हैं, रूटीन एकेडमिक में होते हैं, तो हम इतना चीजें डिलीवर, हम सिर्फ टेक्निक डिलीवर करते हैं, उसकी मॉडिफिकेशंस और हाउ टू अप्लाई वो चीजें और थोड़ी बहुत कहीं ना कहीं डिफरेंस रहता है। तो वो डिफरेंस आज सर की वर्कशॉप के बाद होपफुली वो खत्म हो जाएगा, क्योंकि वी ऑल आर डिफरेंट। टेक्निक्स को मॉडिफाई करना होगा अकॉर्डिंग टू द नीड ऑफ द पेशेंट, अकॉर्डिंग द प्रॉब्लम ऑफ द पेशेंट। तो उसके लिए अभी हम प्रैक्टिकल एज वेल एज थ्योरी ये लेक्चर हमारा शुरू होगा विद इन 1 or 2 minutes मैं आप लोगों को शेयर कर रहा हूँ। और इनॉग्रेशन सेरेमनी के लिए मैं फिर से थैंक यू कहना चाहूंगा वीसी सर को, थैंक यू कहना चाहूंगा मैं हमारे डॉक्टर रवीना और डॉक्टर सोनिया को, जिन्होंने बड़े ही अच्छे से पूरा इसको मैनेज किया, और बाकी हमारे जितने भी स्टूडेंट कोऑर्डिनेटर और बाकी फैकल्टी मेंबर्स हैं जो एक्टिवली पार्टिसिपेट कर रहे हैं टू मेक द इवेंट सक्सेसफुल ऑन सच अ शॉर्ट नोटिस। तो ये अपने आप में सभी के लिए बहुत बहुत थैंक यू सबका। और सबसे ज्यादा तो प्रोफेसर सेंथिल सर का, क्योंकि जब सर आए नहीं थे बीसी सर, तो मैं एक चीज शेयर कर रहा था, सर आगे हैं अच्छी बात है, सर के सामने ही करूंगा। एक्चुअली जब इनिशियल लेवल पे HCAP हरियाणा चार्टर्ड एसोसिएशन ऑफ फिजियोथेरेपी स्टेट लेवल एक्टिविटी ऑर्गेनाइज करती थी, सिर्फ स्टेट लेवल। उसके बाद एक दिन प्रोफेसर सेंथिल सर उन दिनों मुलाना में होते थे, तो इन्होंने मुझे एक दिन एडवाइस किया कि आप इतनी अच्छी एक्टिविटी प्लान करते हैं, इतना बड़ा आपका ये प्लेटफॉर्म आप लोग बच्चों को प्रोवाइड करते, क्यों ना इसको आप नेशनल या इंटरनेशनल करें। तो आप यकीन मानिए कि हमने स्टेट के जस्ट अगली जो एक्टिविटी नेक्स्ट ईयर हुई वो हमारी इंटरनेशनल कॉन्फ्रेंस थी, और वो परंपरा अभी भी चल रही है। हर एक 2 साल में एक बार एक इंटरनेशनल कॉन्फ्रेंस हम लोग हरियाणा में इनिशियल शुरुआत हमने ही की थी। तो ये कहीं ना कहीं गाइडेंस है, मोटिवेशन है सीनियर लोगों का, जिनसे सीखने को मिला, और वीसी सर का भी, क्योंकि ये चीजें अगर टाइमली अप्रूवल होती हैं तो ही पॉसिबल होती हैं। तो सर जितना भी हम जब भी कोई ऐसी कोई प्रोजेक्ट लेके सर के पास पहुंचते हैं, बल्कि नहीं भी पहुंचते तो सर याद दिलवा देते हैं और पूछ भी लेते हैं कि आपका एक प्रोजेक्ट है वो पेंडिंग है तो वो कब तक कर रहे हो। तो ये अपने आप में एक मोटिवेशन और गाइडिंग फैक्टर है। थैंक यू ऑल ऑफ यू, एंड आई एम शेयरिंग द अनदर लिंक विद ऑल ऑफ यू। थैंक यू वंस अगेन।
So we'll end the Zoom and then we start at the other second link, the workshop link.
Right, sir.